Going over to our next speaker, Dr. Innie Chen is one of my colleagues at the Shirley Greenberg Women's Health Center at the Ottawa Hospital, where she has a subspecialty practice for women with complex gynecologic conditions, minimally invasive surgery, as well as pelvic pain. She leads our pelvic pain program in Ottawa. She's contributed to many, many guidelines, SOGC guidelines, AAGL guidelines, presentations. She is a protege of Dr. Allaire and has certainly set the stage to help us with the next presentation. So I'll invite Innie to come up and do that, and hopefully we'll have some more time for questions as well. Thank you, Innie.
Thank you very much, Sony, for the kind introduction, and I also want to thank the SOGC for the invitation to be part of this very special summit. We are a really tight-knit community for those of us who manage endometriosis and pelvic pain, and as mentioned, Catherine was my fellowship program director, and Sony, you've been an amazing national champion and advocate for patients with endometriosis. And Matt does amazing work from McMaster, so it's a real honor to be here today. Many of you will know me more as a researcher. I do hold a women's health research chair, and I'm used to talking about quantitative approaches and epidemiology. But I think today's talk is going to be a bit different. Half my gynecologic practice is devoted to patients with endometriosis and pelvic pain. And today, I think I'm going to talk more about a pragmatic approach. How do we put it together so the patient can understand? And this is what the trainees and our colleagues would see if they come and spent some time with me in our interdisciplinary pelvic pain clinic. We try to answer questions like, why do the patients continue to have pain after they have no uterus and no ovaries? And what can we tell our patients to help them understand the complexity of pain and look beyond endometriosis for explanations? And amid all the treatment strategies that have been presented, how do we select them so that we have a more quicker road to recovery and a better quality of life for these patients? So I want to acknowledge that we are on the traditional land of the Huron-Wendat, the Seneca and the Mississaugas of the Credit, and this land is still the home to many Indigenous people from across Turtle Island, and we're very grateful for the opportunity to be here together today. I do not have any financial disclosures. However, I'm a member of the Board of Directors on the International Pelvic Pain Society, and I don't have any off-label recommendations here. So we're all here today because of the burden of chronic pelvic pain. This affects 15 to 25% of women, according to this systematic review done by the WHO. And from an advocacy standpoint, it's helpful to know and to be able to present that this can be very, very costly to our society and our healthcare system. So here is some work that was published with Catherine and with some of our US colleagues as well. We've already heard many speakers mention the delay in diagnosis in endometriosis. You know, 5 to 10 years basically until a diagnosis is made. But more importantly from this paper is what is mentioned in terms of patients feeling like their symptoms were ignored and feeling like their pain symptoms were or made to feel like their pain symptoms were normal. And I think one really important message we want to get out of today is that pelvic pain is not normal, and also some stigma they face based on their characteristics. The other thing about chronic pain is that there really is a gender disparity. In a report, So first of all, women are more likely to experience pelvic pain because of multiple pain contributors, such they're more likely to have, of course, menses, intercourse, subject to pregnancy, childbirth, and also urinary tract infections. But when they do seek care, they're more likely to be dismissed and more likely to be denied pain medication. So when we put this all together, we can see how menstrual pain, chronic pelvic pain can really impact a woman's life course. So from a very early age, it could impact their education, their relationships, and the choice of occupation. And over time, this can lead to, a change in the trajectory of their lives. And most of this is due to pain. So the learning objectives today are to acknowledge the role of various pain contributors in endometriosis-associated pelvic pain, to recognize the importance of central sensitization and cross-sensitization as a mediator for endometriosis-associated pain, and to discuss interdisciplinary pelvic pain management strategies and trauma-informed care for these patients. So I really want to acknowledge Dr. Allaire for leading these chronic pelvic pain guidelines, and Sonia and I have had the privilege of being part of this as well. We've also received endorsement of these guidelines by the International Pelvic Pain Society, and some of the content in this presentation will be based on these guidelines. So as mentioned, chronic pelvic pain is a common condition that can cause severe distress and considerable burden on the person affected as well as a healthcare system. And we're all gathered here today because it continues to be an enigma, right? These are the patients that are within our specialty. I think of them as the ones in the most need. And, we're here today because many physicians still feel perplexed, confused by what to do with these patients. And unfortunately, it can also lead to feelings of anxiety and avoidance. And I think that sometimes having a new approach, a new philosophy and thinking can really help with this. So I'm going to talk about some common misconceptions that I've seen that we can all as a specialty help address when seeing these patients. So one of the issues in medicine is when we're trained, and very rightly so, we're always looking for that single unifying diagnosis, right? So Occam's razor is the idea that the simplest explanation is usually the correct one. So when we see a constellation of symptoms, we're looking for one single unifying diagnosis. And that's how we're trained in internal medicine. We make our list of, different symptoms, and we try to find one explanation for all of these symptoms. And the idea is that once we find that single unifying diagnosis, the medicine or surgery will help and the pain will go away. And unfortunately, the idea of having chronic pelvic pain continues to have a lot of stigma, right? So once the diagnosis of chronic pelvic pain is made, the patient may hear something, may extrapolate and hear something very different. They may feel invalidated. They may feel that there is no hope and there is no cure. So that is why one of our jobs is to really help to reverse the stigma and to provide hope and allow patients to know that we are there for them to help them along their pathway to recovery. And of course, chronic pelvic pain is not simple. We've already heard about the myriad of associated pain conditions that it can be associated with in recognized chronic overlapping pain conditions, as well as other pain contributors within the pelvis. And that's why in the chronic pelvic pain guidelines, we have this table talking about not only gynecologic pain contributors, but also gastrointestinal, urologic, MSK, neuropathic, and also very important psychosocial and mental health factors as well. So the etiology of chronic pelvic pain can be multifactorial and involve gynecologic, urologic, gastrointestinal, myofascial, neuropathic, and psychosocial contributors, as well as alterations in the central nervous system. And as a pelvic pain care provider, I think that one of the most important things we can do is to help our patients and our colleagues overcome these misconceptions that there is a single simple diagnosis, that, well, we've already know that's not true. And because there's no simple diagnosis, the cure is not simple. And we really do need to reverse this stigma. And with our patients, often we see this grief cycle that they go through, and to help them finally accept their diagnosis of chronic pelvic pain is a very, very important step to their recovery. And because it's so important to work with the patient, this therapeutic relationship is really, really key. And this relationship can impact their satisfaction with care and health outcomes. And at the top of our guidelines, we have this as the first step in the assessment of patients with chronic pelvic pain, which is building a therapeutic relationship. And Dr. Leyland already talked about trauma-informed care and why, and now we understand why it's so important for the patient. And here are some principles of trauma-informed care. So the other thing we need to do is, and I think the other speakers have already alluded to this, to have a systematic approach to this patient. So healthcare providers should have a systematic approach to identifying and treating nociceptive stimuli which can perpetuate pain, and also to discern clinical findings suggestive of central sensitization nociplastic pain. And the International Pelvic Pain Society does have a very useful questionnaire where we can give to patients even in advance of their appointment, and this can help us better assess all the pain contributors. And when we're assessing the patients with chronic pelvic pain, we not look only at the pelvis, but we also assess other parts as well: the back of the pelvis, the abdomen, and then we do a pelvic exam, which is modified, and other basic investigations are also listed here. And here are some things that I do that I find helpful. So when I'm examining the abdomen, we look for cutaneous allodynia, which can be a sign of more centralized contributors to the pain. And we also look for Carnett signs. So this has also been mentioned before. And this is almost like a reverse guarding, because when a patient flexes their abdominal wall, either by raising their head or raising their legs, as in this picture, then you're less likely to depress intra-abdominal organ. So if they continue to have pain with flexing of the abdominal wall muscle, then this is considered a positive Carnett sign. With the vulva, we do a mapping with a cotton swab. We do put some lubrication so it is not as scratchy, and often patients will have concurrent vulvodynia, especially a local provoked vulvodynia at the 6 o'clock position is very, very common, but they can also have I believe this is a form of cutaneous allodynia on the labia minora, labia majora, mons pubis, and thigh. So really mapping out the extent of that vulvodynia and allodynia. As gynecologists who are in my training, we start the pelvic exam with a speculum. However, what I have found is that the patients with chronic pelvic pain have often a lot of intolerance to gynecologic exam and speculum exam. So it's really, really important to go slowly. And if the speculum exam is needed, we would do that at the very end. Also, the bimanual exam, where we depress the uterus and abdominal wall and bladder together with both hands, often is not helpful, because we are basically aggravating pain in multiple organ systems. So what we recommend instead is a single-digit vaginal exam, so involving the pelvic floor, bladder, cervix, uterus, posterior cul-de-sac, and rectum. And and sorry, one thing that's also done is pelvic pain mapping with ultrasound probe as well. In our center, we have specialized sonographers who can help with this, but this can often be done in office as well. But the entire purpose of this exam is to help identify which components of the pelvis are contributing to pain. And once we find our pain contributors, it can be very helpful to document this. So I do this for all my pelvic pain patients. So I will physically draw out the pain for them using a diagram. So for example, this patient may have a right lower quadrant abdominal wall myofascial pain, local provoked vestibulodynia with involvement of the pelvic floor bilaterally. They may have some tenderness of the bladder as well, suggestive of painful bladder potentially, which can be correlated with symptoms, and also some posterior cul-de-sac nodularity and tenderness, which is more suggestive of endometriosis. I find this diagram really helpful because it not only documents the pain contributors, but it also is a physical acknowledgement of the pain that the patient is experiencing. So when I show a patient this diagram, they'll often nod. And this in itself is a form of validation, saying that their pain is not in their head, it's in their pelvis, and it is real. It educates the patient regarding multiple contributors. So when they see this diagram, they understand that it's not just one area that's causing the pain, but multiple areas in the pelvis. And not all of these areas are involving pelvic organs. We have pain on the abdominal wall. We have pain on the vulva. And because they can understand that different pain contributors are involved, different treatment modalities are required. So we're all gynecologists, and I want to start by talking about some gynecologic pain contributors. Of course, endometriosis is a very important diagnosis, and we have come a long way to raise awareness, but we still need to do much, much more. There's adenomyosis, which has also been mentioned, but also primary dysmenorrhea. So I like to just I like this picture because it looks nice, but endometriosis, as we know, is a presence of endometrial glands and stroma outside of the uterine cavity, and we know that endometriosis is related to pain symptoms, dysmenorrhea, dyspareunia, dysuria, dyschezia, and also potentially other presentations as well due to the location of endometriosis and what else could be going on in terms of other parts of the pelvis. Often these patients have chronic pelvic pain. Adenomyosis is the presence of endometrial glands and stroma within the myometrium, and this is more likely to be associated with heavy bleeding, more common in Paris women, present later in reproductive years. But I really want to draw people's attention to primary dysmenorrhea, which occurs in many, many more women than we know. So this is pain occurring with menses in the absence of pelvic pathology. And 90% of women will experience some menstrual pain, 30% experience moderate to severe symptoms. And again, this can be also associated with frequent life changes, fewer social supports, mood disorders, pain hypersensitivity. So again, those same psychosocial contributors. So my belief is, regardless of whether the patient has endometriosis, adenomyosis, or primary dysmenorrhea, the pain they experience is not normal. And because of this, they deserve treatment, they deserve attention, and they deserve our care. And one thing that we can do, which can be very effective, is menstrual suppression. So here is a systematic review that we're showing benefit with treatment for patients with primary dysmenorrhea. And I'm not going to go into how to treat patients medically. I believe that we're all familiar with various menstrual suppression strategies. But just sometimes it's useful to see that, that this is definitely an effective strategy. For patients with endometriosis, we know that progestogens can be helpful for menstrual suppression as well. And I know that the guidelines are currently being updated, but the idea that we would still start with menstrual suppression, medical management of patients with dysmenorrhea, with endometriosis is still very helpful and something we espouse. I did mention that this is going to be more of a pragmatic approach. So here are some barriers to menstrual suppression. This is what I hear from my patients about why they're hesitant to be on menstrual suppression. So first one is I tried it and it didn't work, right? So this is where it's really, really important to tell your patients that that we really do need them to try this medicine for 3 to 4 months to know if it's actually going to work for them. So I do try to provide some realistic expectations. A lot of these patients are more sensitive to medication and medication effects. So I do say, you know, the majority of patients will respond positively and favorably to this medication, but there's going to be a small percent, maybe about 20% who don't. But everybody's different, so unless we try it, we're not going to know. So we do acknowledge that it does take some courage to try a new medication, and then it really is up to the patient as to whether they want to move forward. But until they try a treatment, it will be very difficult to make any changes in their quality of life. I tried it and it didn't completely take away my pain, and this is true. This is to be expected based on what we already know of endometriosis-associated pelvic pain. And then I take out my notepad and I draw a picture, and it often looks like this. I say, there's your daily pain, the line across the bottom there, the second line. And then there's your menstrual pain. And a lot of patients will nod and say, yeah, that looks like my pain. So it's very difficult to treat pain that's going up and down every month in a cyclical pattern. So I say, when we do menstrual suppression, we don't expect all of the pain to go away because you have multiple components of your pain. But what we do expect is that the pain that you have with menstruation, the one that where you go to the emergency for when the 9 out of 10, 11 out of 10 pain, hopefully that will at least be alleviated. And then this gives us a chance to start working on some of the other pains that you may experience. So the next thing I hear often is not having a period is bad for me, or hormonal suppression is not curative and maybe just a Band-Aid solution. And this is where I think it's important to provide some education about endometriosis. And of course, the endometriosis and adenomyosis is not exactly like the endometrium, but for patients who require, commoner approach, it's important to be on the same page. And I take out my notepad again, and I'm very visual, and I draw a diagram such as this, and I say, this is the eutopic endometrium. That is normal, that is supposed to be there. But here we have endometriosis, which is like the endometrium, and that is, because it's not, it is ectopic and not supposed to be there. That in itself causes the inflammation and the pain that you're experiencing. And what we know about the endometrium and endometrium-like tissue is that it is hormonally responsive. So estrogen causes stimulation and progestin inhibits it. And that's why it's important to try medical management. That's why the lack of menstruation does not cause a buildup of menstrual tissue in the uterus. And that's why we do feel that this is a long-term strategy and not just a Band-Aid solution. So progestogens and gonadotropin-releasing hormone agonists or antagonists should be considered in the management of chronic pelvic pain, especially in the presence of cyclical exacerbation or endometriosis. So for I want to talk a bit about some other pelvic pain contributors. The first being myofascial pain. This is the most commonly overlooked pelvic pain contributor. 40% to 60% of patients have this, and this is based on work from BC. In my patients who see me at the Pelvic Pain Center, 80 to 90% of people have some form of myofascial pain. And for this, pelvic physiotherapy is a cornerstone of treatment, though nerve blocks may also be helpful. So physiotherapy assessment and treatment should be offered for chronic pelvic pain management. Other organ systems, painful bladder syndrome, previously known as interstitial cystitis. A cystoscope is no longer required for a diagnosis. This can be diagnosed clinically, and we're fortunate to also have a urologist with us at our interdisciplinary center. But prior to referring to him, I will often start a patient on a bladder elimination diet, start some central acting agents, which we can talk about in a bit. And but it's nice to have that interdisciplinary team approach. Irritable bowel syndrome is very, very common as well. This is a functional bowel disorder in which recurrent abdominal pain is associated with defecation or a change in bowel habits, and the Rome criteria is shown here. For this, I will often refer to gastroenterologists to rule out any other concurrent disease, but a first-line strategy is a low FODMAP diet. It's also been shown that menstrual suppression can also help with this, and as well as some of the centrally acting agents. So I know this is a question that came up quite a bit, and will surgery help? And I know that people already have some ideas about this. I will share with you mine. So debulking disease is helpful, of course, we saw that, right? And the diagnosis can often be very validating, or a lack of diagnosis can also help the patient move towards acceptance and move towards alternate treatment strategies. But I think it's really important to set appropriate treatment expectations. So you see this diagram on the top right showing the multiple pain contributors. And I pull out this diagram and I say the endometriosis surgery will treat the gynecologic symptoms and the gynecologic organs, but after we do surgery, if we were to move forward, we would still have to do lots and lots of work on some of these other pain contributors that you have. And we do have good evidence that that hormonal suppression following surgery can be very helpful, shown in the previous systematic review. And as we know, pelvic pain and dysmenorrhea, dyspareunia are coexistent. That is why because of the different pain contributors, the Cochrane review states that we are uncertain of the effect of laparoscopic treatment on overall pain scores and quality of life. And there is some, but nonetheless, surgery can, of course, be helpful for some patients. So surgery for chronic pelvic pain may be offered after pain beliefs and treatment expectations are explored, and with counseling about rationale for surgery, the uncertainty of the evidence surrounding outcomes, and the possibility that pain could be unchanged or worse postoperatively. And in terms of some of the centrally acting mechanisms, we know that the presence of cutaneous allodynia, hyperalgesia, pelvic floor tenderness, and chronic overlapping pain conditions are suggestive of central sensitization. In the past, our idea of pain was that you touch something painful like fire, and the nerves would send a signal to your brain and you would feel pain. And now we know that pain is much more complex than that. There are ascending and descending pathways, excitatory and inhibitory mechanisms. And again, that leads to the complexity of pain. And this can be further exacerbated by the coexistence of trauma and also fear, anxiety, depression. And for these patients, we need to be even more careful and gentle with our approaches. And that is we do believe that there is altered pain processing at the level of the central nervous system, and that is what we mean when we talk about central sensitization. And these psychosocial factors, such as pain, catastrophizing, fear, and fear avoidance, mental health conditions, can really lead to the perpetuation and intensification of chronic pelvic pain. And for this reason, these patients really do require a lot of time. Pain neuroscience education should be included, and psychologic treatments should be offered. And in terms of what medicines we use, we really do believe in foundational analgesia with NSAIDs and acetaminophen. We really do discourage the use of opioids. They are not recommended and could potentially lead to opioid-induced hyperalgesia. For me, a central first-line agent is a tricyclic antidepressant, so amitriptyline or nortriptyline, but starting at a really low dose, 10 milligrams, increasing by 10 milligrams each week, up to 50, and then reassess from there. We know that SNRIs can be helpful. And what we also know for these patients is that interdisciplinary management can be very, very helpful. So I'm lucky to work at the Shirley Greenberg Women's Health Center for my surgical practice, but I'm also part of a pain clinic where we have access to allied healthcare professionals. And these professionals come from a variety of disciplines to work together for the benefit of a single patient. And here are some principles of good interdisciplinary teamwork. As a team, we also participate in CME together, and I want to highlight the International Pelvic Pain Society as a really, really great resource for anyone seeing pelvic pain patients. They have informational handouts, various CME, and opportunities to connect as a community of pelvic pain providers. And of course, we have our annual World Congress, which was just in Colombia this year. And we know that interdisciplinary care can be very helpful for patients, helping them improve their physical, psychological well-being, return to work, and reduction in healthcare utilization. So, you know, we tried to create an approach for these patients, but as Matt mentioned, every person's approach needs to be individualized. So when we started working on the guideline, I tried to put it together, but this really is much too prescriptive, and there is no single path for each person. So what I have instead is a more generalized approach. And on the top left, you'll see that in my mind, the visceral conditions should be treated first, and then we can move on to myofascial, and then the central, because the truth is when they come for their first appointment and they leave with 10 different strategies, that can be very, very overwhelming. So how do we help them decide which ones to do first? And this is really just a guide. So first, menstrual suppression, if possible, concurrent pelvic physiotherapy. Once the patient has had menstrual suppression, move on to psychologic therapy and an additional neuromodulating medication. And all of this is on a foundation of trauma-informed care, pain neuroscience education, and interdisciplinary care. And finally, I want to mention that pain is not suffering. Sometimes I'll see a patient and their pain score is 7 out of 10. And I'll see them 3 months or 6 months later, and maybe their pain is 5 to 6 out of 10, which really doesn't sound like improvement. But the truth is this patient was able to go back to school, or go back to work, or go to the park with their kids. They're not lying in bed all day. So for me, the quality of life and function is much more important than the pain score. Thank you very much.
That was great, Innie. Thank you so much for a great overview. And we do have time for some questions, both online and in the back. And just a reminder, so after this, we have a good amount of time for lunch and networking. And then in the afternoon, we come back. And if you do leave, you can sign on online and continue to listen as our afternoon speakers are compelling and got quite a bit to cover as well. I'll go ahead with our first question from the floor.
Hi, I'm Brittany. I'm currently practicing in Sarnia, Ontario. Thank you for the talk, very excellent. I think where we struggle in the community, I mean, we hit lots of OR time, so surgically, we are very helpful to our patients. Medically, very good at suppressing menses and pelvic pain that way. I think where we're failing people is the multidisciplinary aspect. And we just don't really have the resources for that. In Sarnia, we're very lucky. We have one physiotherapist who's really good at peripheral desensitization, but we don't have mental health professionals and that kind of thing. So I guess my question is, are there options for us for remote access for these services for our patients? Because I think that's where we're failing them.
That's a really great question. I'm sure many care providers struggle with the same concerns. And I think it is very, very difficult to treat chronic pelvic pain patients in practice. These patients take more time. So one of the first things I find helpful is to book, maybe dedicate certain days a month for these patients so that you're not rushed and you can provide the time for these patients, often involving an allied health professional, even like a nurse practitioner, physician assist, or a more specialized nurse in your clinic can help also with a lot of the work. Without kind of interdisciplinary care, what providers can do is they can start to form networks outside. So if you have like in Ottawa, I think when I first started, there was maybe 1 or 2 pelvic pain physiotherapists that we knew had the same philosophy, and we would form a relationship. Now we're very lucky there are many more. Pelvic physiotherapy is difficult to do remotely, but it can be done. I have colleagues who do that. And psychology is I think, more amenable to remote care, but that has been one of the benefits of the pandemic, which is an increase in virtual access to care.
So a couple of things to add, and I just realized we probably share some online resources with you. So the Ottawa Hospital, along with Sick Kids, along with Memorial, have got access for your patients for a power over, what's it called? Power Over Pain portal. So something for you all to write down, Power Over Pain portal, self-directed education, chronic pain resources that you would get in any pain clinic across the country. And so Power Over Pain portal, it's available. There's an HCP side, but the patients can get their education available, and we use it in Ottawa and have bought into it. So Power Over Pain, and it's something we give. The other thing is we're going to give you a link to, or you can just go on to OMIG, not OMG, omig.ca. And if you go to the healthcare provider resource, I'll give you the password later on. It's capital HCP space 2024. We're going to upload all of our resources, including our counseling materials and videos and everything else. So when you're in Sarnia, you can get people started while they're waiting for these things. And in Toronto, we also have the TAPMI, so TAPMI. Program, which again has online resources. Catherine's website has online resources. So what we've done in each clinic, and if you do that, is build your own resources. You can say, we may not have access, but I really encourage you to go onto this site, and it's a lot of self-directed education. So I'll try to share some of that through the SOGC. It's a total miss in my mind that we forgot to do that, but I'll make sure we continue to share those. Matthew, and then Charmaine.
Thanks for the great talk, Innie. I always learn something when I hear you talk. What I'm really curious about is how you set the stage with the patients. So I like to prescribe lots of these different things as well, like you, but doing too much in the first visit is overwhelming, and also starting different things at the same time is also sometimes not so logical. So how do you set the stage with the patient? What's the frequency of visits? Like, do you see them after, a month, 3 months? Because we have resource limitations and these patients do take a lot of time. So I struggle with kind of planning that care and the introduction of multiple different things, like when to plant the seed, when to introduce, you know what I mean?
Mm-hmm, absolutely. So I think that's where readiness for change is really important. So, when interviewing these patients and getting the history, we also ask, I remember as a medical student learning the FIFE, the FIFE, and it's actually really helpful here because you get a sense of what they're expecting and what they're wanting out of the visit. And based on that, we try to match where they are. And in the meantime, I think the education is really important. So that's why new patients are 1 hour and follow-ups are half hour. Having the, I do a lot of virtual visits as well, and that's been very helpful to be able to provide access to more patients. But in general, every 3 months until patients are on the trajectory to improvement. But I cannot emphasize the importance of menstrual suppression, because what I find is if patients are not menstrually suppressed, they may do pelvic physio and do everything else, but the moment they have that menstruation, they go to the emergency, they're back to square one. Thank you.
Thank you, Charmaine Roy, Ottawa. Thank you very much for that presentation. It actually is a perfect segue from your comment about menstrual suppression. Some of them won't start the menstrual suppression, not that they've started it and it's failed, because the last 2 doctors they saw, they just gave me the pill, and they may not need it or want it, or they're in a same-sex relationship or something like that. And then you try to explain that even if you have endometriosis, it's often the first step, but there's something about they want to know what they have before you treat it. So I think we can't get more universal imaging fast enough, but if there's anything you could help us with what to say with that pushback, how can you treat me if you don't know that's what I have? Thank you.
I think that that's something we all struggle with, and that is why, you know, in my presentation I tried to emphasize some of the challenges we might face with offering menstrual suppression as first line. And beyond what has been presented in terms of helping patients understand there are really multiple components of their pain, and that the menstrual suppression is just one piece. I do emphasize that it may be the most important piece, and also for the endometriosis guidelines, what we know is if we find endometriosis at laparoscopy, after we find endometriosis, our recommendation will still be menstrual suppression. And because it does not change their need for menstrual suppression, we may be able to avoid surgery if we start there. But like Matthew, I don't take surgery off the table as an option, but I do explain my rationale because of, obviously there are risks to surgery as well.
That was a great question and dialogue as well. We're going to get more into the panel discussion, into the specifics. And so what we can do is I'll ask Dr. Chen and the others to collect some resources, and during the panel I can put up a slide where we can upload everything. Again, great point that we should share all this, including the videos and information. And again, Catherine's website, just look up Catherine Allaire will solve all the problems, and that'll be up there. So go ahead and have a great lunch. We'll see you back at 12:30. Thank you so much, Dr. Chen and others, for this great morning.